Did you know that there were HRAs before there were HRAs? Yeah, that's what I said. What did I mean? We'll find out on this episode of ShiftShapers.
Change either energizes or paralyzes. The choice is yours. This is the ShiftShapers podcast, bringing the employee benefits industry interviews with individuals and companies who are shaping the industry's shifts. And now, here's your host, David Saltzman.
And to help us answer that question, we've invited David Sloves, CEO at Nonstop Health. David, welcome to the podcast.
Thank you, David. Pleasure to be here.
Thank you so much. And it's all our pleasure, but give us a little bit of your background. How did you get to be doing what you're doing today?
I am a lifelong entrepreneur, startup guy, and fell into the healthcare business a little over 20 years ago when I had an investor in a prior business who I owed a favor to who called me on it and said, I have this business where I administer benefits for a union, and the software I'm using is 15, 20 years old, help. And I found out later he had just sold his business and was on an earnout, so my help was very instrumental to him. And through that, I got a quick look into the healthcare system and decided that what I had done in tech and what I wanted to do in healthcare lined up very nicely, and have been in the healthcare world ever since.
So when I mentioned early on that we were talking about HRAs before HRAs were invented, what we're talking about is something called a MERP, M-E-R-P. Broad terms, David, what's a MERP?
Well, a simple term, the initials MERP, Medical Expense Reimbursement Plan, kind of says something and nothing all at once. But essentially what a MERP does is it allows you to use the IRS tax preference model for employers funding healthcare. And it has been around since the 1950s. And what it does essentially is it allows an employer to put funds in for the expenses of a high deductible health plan in our usage. And those expenses then get covered by our administration of the expenses. And then we throw in a few extras on top of it to make it a very interesting outcome for both employers and employees.
So for practitioners, how does it differ from an HRA and how is it the same as an HRA? Or is it?
An HRA no, it's actually fundamentally different. HRA, much like an HSA or an FSA, is a per participant plan in which a block of money is contributed and then utilized for expenses. In the case of an HRA, the employer puts it in 100%. In the case of an HSA, both the employer and the employee can contribute. And in an FSA, the same holds true. The difference is that FSAs are very limited in how much money can be put in per year per enrollment. HSAs are limited but substantially larger than FSAs, and HRAs are unlimited. And what we've done with the MERP is we've taken advantage of that capability to allow a highly customizable financial outcome with a very predictable algorithmically outcome for the employer and the employee. And effectively, we've de-risked the self-insurance component of healthcare.
That's fascinating. So let's talk in real terms. What's the problem that we're solving by using a MERP?
So the MERP addresses one of the most fundamental problems in American healthcare, which is costs are skyrocketing at 3-4 times the annual inflation rate, going on 40 years. And even though the employer is using tax preference money, the expenditure has reached the point of pain for the employer. So employers have shifted more of the burden of cost onto employees, both through the contributory model to the healthcare programs they offer, i.e. how much you pay, how much I pay, and also through the way the plans themselves are designed, so that more and more of the expense of direct consumption of retail healthcare, the day-to-day stuff, doctor's visits, testing, prescriptions, is borne by the employee, despite the fact that a substantial portion of their income is represented through that employer funding of a healthcare program. So we really take aim at that. The secondary problem beyond the cost problem is that over the last 2 generations, the American healthcare system has slid in efficacy to, people will unkindly call it a third world health plan. And that's really not true. Having been in India and other places in the third world, That's just not what we are. But against the benchmarks of the top OECD countries, we are at the very bottom now. And people will say, well, that's because you're insured versus there being state plans. And that's not true either. The two of the five best health plans in the world, according to the World Health Organization, are the French and the Japanese, who have very little in common, other than they have insured plans that work well. And so it's not necessarily the underlying capitalist architecture of American healthcare. It's frankly the way in which it's operated, which has become less and less wholesome financially and frankly ethically. And we really look at that as another area we can take aim and deliver a superior outcome.
So we've talked about this on the podcast frequently. We've essentially created a group of people that we call functionally uninsured. They have a
Yes.
medical plan, they have an ID card in their wallet, but they can't really afford to use it. How
Exactly
does
true.
this, how exactly, let's talk about how this works in practical terms. We've got, Joe, and Joe makes 40 grand a year and has two kids and a spouse and has a huge deductible and a lot of out of pocket. How does this come in and play with his existing core medical plan to help him not be functionally uninsured?
Sure. Well, it's worse than functionally uninsured. He's really at this point, if he's using the health system, he's bankrupt, and whether he knows it or not. When we come into new client situations, we meet with the staff in private meetings, one-on-one. We're often told, "Well, I have these 3 credit cards maxed out. Are you going to make that go away?" And the short answer to that is we can't change history. But what we do is very fundamentally different. We have a 100% first dollar coverage approach. We will not offer our program if employers will not honor that requirement. And what that means simply is there is no deductible. And the first dollars that they have, whether it's office visits or emergency rooms or prescription drugs or whatever it might be, they're provided with a funding mechanism. And in addition to that, the funding mechanism is a Visa card so that they don't ever have to write checks up front and then wait for reimbursement. Because your example, a 40K worker with a wife and 2 kids, even if there's a 2 income household, they're at or below the poverty line. And so the reality is they're making choices of $50 and $100 payments for various deductibles or other expenditures that are competing not with going to the Bahamas on a trip, but paying their rent, paying their electric bill, paying their water bill. And so it's not shocking that in addition to being under or walking uninsured, they're also getting worse. Their health is getting worse. And it's become a very fundamental problem because with healthcare, the basic truth is that it's not a linear function. And so if you don't do the earlier low cost elements, like most complex systems, you pay later. I use the example of the car industry where a defect in design can be fixed on the design system for pennies, maybe dollars, worst case. And at the very far end of the spectrum, you do a factory recall of Ford F-150s and it costs $50 million for a problem that could have been solved for 25 to 50 cents. And the healthcare system has a similar exponential curve to it. And so the first dollar notion we have has been a game changer for people. We are routinely besieged with thank yous for anything from a child who they couldn't afford to put tubes in there and the child was deaf as a result, to cataract surgeries deferred that they can now get done, to, oh, I didn't know I had this chronic problem. I just was tired all the time. And once we got on your plan, I went in, I had a simple chemically fixable problem for $500 after 15 years of poor quality of life. And so this isn't just a financial issue, it's an ethical issue. And we believe that the first dollar coverage model is so much the reason for our end user experience being superior.
So if I go to a provider, do I just give them the Visa card and say, hey, whatever the insurance doesn't cover, charge to this, don't send me a balanced bill?
Correct. Literally. So what happens is, let's take the 2 or 3 most common transactions. I go to the doctor. Okay, it's not a preventive cover. I'm on an insured plan, PPO, HMO, POS. It makes no difference. And a traditional plan might have had a $25 or $50 deductible. That might have prevented me from going. It might not have. But now I go and I've got this HSA $6,500 deductible plan. And so the provider checks your card, they look at your insurance with XYZ insurance company and say, okay, you owe us $114 because they know that's what the charge is going to be adjudicated at. And the employee hands them the credit card, they swipe it, and they're done. And then the back end process of the 4 or 5 billing steps all occur invisible to the employee, but highly visible to us in managing their employer's funds. And so that's the most common transaction at the service side. And then in the pharmacy, obviously, it's even easier because then it is adjudicated to the penny. And again, they give them their carrier card or it's on file. They look it up. They see that HSA plan as an example. And they go, okay, well, you're buying this generic at $6.22. Swipe. Or you're buying this non-preferred branded product and it's $1,120. Swipe, done. And so you don't have people splitting pills, and you don't have them missing cycles, and you don't have them going through all of the known decay and chronic conditions problems that you get when people can't afford the co-payments and the deductibles.
And now, a word from our sponsor. This episode is sponsored by MZQ Consulting, a concierge compliance firm that excels at making the complex simple. Have you seen the news lately? Johnson & Johnson is being sued because J&J's health plans failed to negotiate lower prices for prescription drugs. In the case of one drug, the plan paid $10,000 for a drug that regularly is available for under $80. Not only were the members of the benefits committee named personally, but their benefits advisor was also named in the suit. And that, dear listeners, is why you need a top-flight compliance firm. Yes, MZQ handles all the usual compliance stuff from ACA reporting and tracking to wrap documents 5500s, mental health NQTL and QTL analysis, and a whole lot more. But the heat is being turned up on fiduciaries who don't act like it. In this environment, using an ERISA attorney-led compliance consulting firm is your best strategy. Your clients too. And MZQ Consulting is where you should go. For more information, go to www.mzqconsulting.com or email them today at engage@mzqconsulting.com. Now, back to our conversation. So as an employer, do I have a lot of flexibility in how I design this plan?
You do. I mean, the thing that we did early on, it was 0, 0, 0. No deductible, no co-payments, no out-of-pocket, as long as you stayed in network. But there were 2 problems we ran into with that. Some of the carriers objected to that model. The employees didn't have enough skin in the game. A point of conversation for another time, but ridiculous given how much of their wages go into healthcare. But the other issue is the employer couldn't customize to fit a price point. And what happened is that in many times, we were an overwhelming savings for them. And typically at the low end, we'll save an employer 10, 15% on premium the first year, and it compounds another 2 or 3% each year. So we have clients who've been with us 7, 8, even 10 years who are saving 40% over a traditional plan now with the same carrier in the same network. But we also have clients, particularly in states where the spread high to low is smaller, because obviously in the American market, you have states that are super expensive for healthcare, Alaska, New York, California, and you have states that are a lot less expensive. Traditionally Texas, Florida, some of the other states in the Southeast. Well, first of all, inflation's caught up with everybody to some degree. It has made the problem for us lesser because everybody's way up there now. But also, if I've got a budget to meet, and I've been giving people a low plan that was, we'll call it in metal tiers, a silver plan, and then a buy-up option to a gold plan. With our model, we can give you the first dollar coverage, and we can give you a low plan that has $2,000 or $3,000 of back-end exposure, the last $2,000 or $3,000, and a buy-up to a full no exposure option. And what it does, frankly, is it allows people who know they're heavy users to do the buy-up in a very small increment and have nothing out of pocket. And it allows the lower users to buy the lower cost plan. But everybody gets the first dollar coverage. And so let's assume it's, again, a $6,500 out-of-pocket exposure. and the employer provides a $2,500 option in exposure for an employee-only plan. They get $4,000 in first dollar funding before they hit it. 90% of people will not get to that $4,000. And if it's a family coverage, any kind of dependent, they get double that. So then even if one person is maxing it out to 6,500, they still have another 1,500 for the other folks on the plan. And so what happens is people who know they're not chronic users and are comfortable taking a little risk can buy the lower cost plan through their employer. And it gives the employer tremendous flexibility. I hate using other people's market risk, but it's a name your price health plan where you can pick where you want to be on that curve. And we let people dial it up or down. And year to year, they can change it and they can offer multiple options. And people go, well, isn't that going to lead to an adverse pool? Well, the answer is no, it doesn't. It's the same overall group of people. The same fractional number of people hit the out-of-pocket maximum. And so because that's a small fraction of the population, the overwhelming number of transactions, and frankly, even the dollars, live in that first $3,000 to $4,000 of spending in our model because we don't get the shock claims. Effectively, if you think about it in self-insured terms, we use the carrier out-of-pocket maximum as our specific limit for any given employee. And instead of it being $100,000 or $200,000 or $25,000 even, it's typically $6,000 to $9,000. So it makes each of those heavy users one unit, but a small unit against the overall average versus that massive gap in a full self-insured product.
Do you have any data, anecdotal or real, about what the impact of employees having this first dollar coverage is on claims from deferred care?
We do. So the most telling information we've gotten is our largest groups over the years get much more detailed access to information. And some of our mid-tier groups where we have Springbuck or other analytics chassis that see the full claims run, the first thing that happens is literally in the first year and then compounding thereafter, the number of inpatient days per 1,000 member months drops steeply. So again, that whole notion of any complex system, basic rule of Deming quality assurance models is solve it early, solve it cheap, works here brilliantly. And so what happens is office visits go up, they use the card, fills on generics go through the roof to almost to 100%. And what happens is you get less serious conditions. And I use a simple illustration for people. If 100 people all have a bad upper respiratory infection and none of them go to the doctor, a fair number of them are going to end up in an ER, and a fair number of those are going to end up in a hospital and possibly with chronic conditions. If 100 of them go to a doctor, the 90 who need simple generics and they're done, great. We probably could have used over the counters and those 90 people would have been fine either way. And we just spent $9,000 in doctor visits and another 1,000 in generic drugs. Okay, so we spent 10 grand, but the 10 people who we spent the next $1,000 on, if one of them hit an ER, they were cracking past 1,000. So the break even fiscally is one of those 10 people. And if one of them would have had an inpatient day starting at $20,000 at the hotel hospital, we're so far ahead, and people have less sick days. They have less contagion in their own household and less on the broader marketplace in which their families function. And so you get a community wellness outcome, whether it's workplace or more broad, based on that notion of fix it early, fix it cheap.
Yeah, when I was a TPA, we used to use the example of little Johnny who got a cold, and parents said, well, we can't really afford to take him to the doctor, so we'll wait. We'll treat him with over-the-counter stuff. Fast forward 10 days, little Johnny is in pediatric intensive care with pneumonia
Right.
that damn near kills him, and that's a $90,000, $130,000 bill.
Yep. And that's the curve. I mean, and the reality is, again, that people go, well, you're being an alarmist. What fraction of people? Well, it doesn't matter, because at any percentage that is an efficacy-based analysis, it's a huge win to get people to the doctors. Every insurer in the country would argue to that point. Every physician in the country would argue to that point.
Sure.
Nobody really questions that logic. And honestly, there's no reason to question it. It's just obvious systemic truth.
So if I'm an advisor, A, how do I integrate this into what I'm already doing? And B, what's the conversation like with an employer who is maybe skeptical and hasn't heard of a MERP since 1970?
Or ever, right? I
Right.
mean, because they're a relatively recent phenomena, honestly, people didn't test the tax code on this for a long time. It was just done on a per account basis. Um, what, and to be honest, our number one competitor in almost every situation is it's too good to be true. And when we were starting out, we sold directly. We went directly to the employer. We had very sophisticated materials and supporting processes. We partnered with medical associations, the community health center movement notably,
Mm.
and we were able to overcome that inch by inch. It was slow rolling, but you get to the first 10 or 20 groups in a community, and it's referenceable. And too good to be true goes from an overwhelming problem to a problem. And now we're at 500 employers later, basically. And now, too good to be true is okay, well, would you like 10 or 20 references? You want them in your state, your industry, your carrier? Which combination would you like?
Mm.
And so we rather quickly get that. But the more fundamental problem for anybody selling any program into the medical system is the inherent problem of friction, of inertia, of, well, we've been doing it this way. And we we have now almost 1,400 brokers around the country, brokers and consultants who work with us at over 100 agencies, probably at this point close to 300 agencies. And we give them a number of supporting materials. We've got a training program we offer them, not just on what a MERP is, but how to deal with change and how to position change effectively. And we've brought in real expertise from the academic community to support those programs. And we make all this available on a no charge basis to the community because, again, we believe the change is fundamentally critical, not only for our fiscal outcomes, and of course, we want to be successful, but also for this whole notion of community. We started as a mission based company and we retain that approach. We believe it's a basic human right to have access to healthcare. And it's not, to me, a political argument about, well, there's a government or non government, because at the end of the day, that's not the point. You know, you can make whichever argument your politics you want to make. I'm indifferent to that problem. To me, the problem is how do you actually make good on that commitment, and that's really what we've approached. And what we've done, really, I mean, if you ask our clients, they'll tell you we save them anywhere from $1,000 to $3,500 a year per enrolled employee in premium. It goes up over time. The renewals are better than they've ever had before, and if they want to move from a partial self-insured, the MERP model, to a fully self-insured, we can tell them their risk profile. We can help them with our consulting partners make that transition. And maybe 5-10% of that marketplace is interested in doing it because the people who are in that program are people who are in the insured system 90+% of the time. We work with carrier ASO plans and TPA ASO plans, but at the end of the day, the bulk of the clients we serve prefer to be in the safety net of the traditional carrier model. And so we give them that migratory path, but more importantly, we reduce the employees and the employers' inflation dramatically. And dramatically, really, the context of this isn't a few percentage points. We're talking about compounding. It gets up to 15 to 20% almost automatically. And it's not a speculative thing, it's math, because we pass through the reserves algorithmically with simply the underlying inflation, not the administrative inflation. In 12 years of doing this, we have changed our rates upward 0 times, 0 inflation in 12 years. The reserves that we're collecting for these transactions, which are not the hospital and not specialty drug, because those people hit out of pocket and we're done with them. So that doesn't inflate. And so our inflation rate is 2-3% on an annualized basis over the last 12 years. And even in the higher inflation in society over the last couple of years, it's been 3 or 4%. Compare that to the carrier inflation rate for 2 generations of 7+%, and in the last 5 years of 9% compounded. And you can see what's going on because they're only buying 60% of the carrier inflation rate with these high deductible plans. The other 40%, a quarter of it has zero in inflation, the rest has a 2 or 3% inflation rate. And without setting up the fancy equation, which isn't that tough, you get another 2 to 3% automatically every year systemically in the way our product is designed. So the number two skepticism for employers is, well, what's going to happen? You're just buying the business like a carrier would. We go, no, we renew algorithmically, and our average renewal is under 3%, including your carrier inflation rate. And they don't believe that. So we show it to them, we give them references. And the reality is almost a third of our clients get a rate pass the first year. And by that, I mean our reserves, our fees, plus the carrier inflation on their underlying plan means they pay the same thing all in for that Nonstop Health bundle that they paid in year one. And if you ask consultants how many rate passes a year they get per 100 groups, you would find that the number is somewhere between 2 and 0. And so the fact that a third of our clients experience that and it's referenceable has become a very viral effect for our consulting community.
We've talked a lot about hard dollar costs. I'd like to end with two other questions. The first is, how much do you find employee satisfaction going up, and how does an employer measure that? Is it just lack of gripes going to HR?
Well, I think the squeaky wheel is always the one that gets the most attention in the executive suite because we don't want this aggravation. That's why we have HR. Is kind of their first reaction. Guilty. Okay, I'm with them. And we measure it every year twice for all of our members. We do surveying. We have done surveying as a practice for 7 or 8 years. We measure our satisfaction on any number of metrics with each of our service teams, and that includes everything from how the experience was in getting on the plan, how was your renewal, how is your usage of the card, when you have manual claims, how is that going, when you call us and ask for help, how well do we do there? And so we have very detailed surveying. We get a very high response rate. I think our low response rate is in the 20% level, and sometimes it's higher than that. So we're very actively managing to that. And so when we see changes where our growth is impacting people, good or bad, we're pretty able to pinpoint where in the service delivery system we either have done something really well or not done well. And it's a continuous improvement model. I mentioned Dr. Deming's work earlier, and I'm a huge believer in the notion of continuous improvement and statistical quality. I came out of the 80s working with manufacturers in that world, and it's always been important to me to understand that when you're growing as aggressively as we have, and we've been growing at 30, 40% a year for years now, you have to really be measured in your understanding of the user experience. But one of the things we did early on is we revolutionized the way credit cards were used for MERPs. Historically, you could only use them basically at a pharmacy, okay, because that was auto adjudicated at the point of sale. And we said, that's silly. We know it's an in-network transaction most of the time, and why don't we let them use it for everything and algorithmically determine when we need to ask for paperwork? So we end up sampling about 3% of our transactions by number and by dollars to make sure that they are following the rules of our plan design. And as you might imagine, the compliance rate is extremely high. Somewhere in the neighborhood of 94 to 96% of the transactions are observably correct out of the box and don't need us to touch them. And of the 3 or 4% that do, even those 85, 90% are legitimate transactions. And so the historic model of make 100% of the people pay the price for the 2% of bad actors, we just flipped the script on it. And at the end of the day, we've been able to do that while bringing our service costs down over time. And that's why our prices have held constant on the service over more than 10 years. It's not that we're not inflating wages. We are, of course, and offering more services. But I kind of look at the Apple model of how they've priced devices over the years as a really powerful consumer loyalty builder. Hold the price constant and keep giving people more and more value for their money. Then people can budget, they can get used to that, and they get a better and better experience over time. And this is an industry where whether you use the net scores or the net promoter scores or any other metric, has terrible relationships somewhere in between congressional representatives and lawyers is where the healthcare folks fall in. And we're sitting here running at a whole nother level. And, we look at our satisfaction levels and we're typically in the high 80s to low 90s of people grade us a 4 or a 5. And we consider a real problem if we're not at 90 plus in that for any client. And we go back to the team and go, okay, what are we not doing right here? And, some of the things that we've learned is bilingual requirements.
Mhm.
So now our entire organization runs bilingual, English and Spanish. And whether it's printed materials, web content, emails, or human beings live on the phone, it's available very easily in either language. That all by itself had a huge impact. And less people think that's purely a California, Florida issue or Texas, Florida, California issue. No, no, no. We have clients, particularly in the nonprofit world of community health centers, who are serving farm worker populations and other migrant populations all over the country.
Mhm.
One of our biggest centers that's bilingual is in North Carolina, another one's in Illinois. And so for us, this has been a huge improvement in how we come to market and something that seems obvious after the fact. But before the fact, employers, oh, we don't need that. And then we find out, well, actually, you do need that.
Yeah, lots of things seem obvious after the fact because we all have 2020 hindsight. One last question. Do you get comments from employers after a year or two of implementation that this helps them attract and retain employees as well?
Uh, Honestly, that was one of the postulates we had at the outset that people just kind of went, yeah, no. And then I think it was about 2017, I think we were about 4 years into it. The National Association of Community Health Centers was a big partner of ours, and we were at one of their national conferences. And one of our clients was in a room filled with CFOs and said, look, because it was about recruitment and retention, and it was
Mhm.
a particularly difficult period for them to recruit people. So, look, I can tell you the magic's off for us. It's nonstop. And people went, huh? And the CFO went, our retention rate has gone up massively. We used to turn over 38% or something like that of our non-professional workers every year. And now we turn over 9%. And people went, no, that's BS. And what we've discovered is that part of the messaging, as much, maybe more than even the financial messaging, has really carried the day. And particularly as we went from direct to working through brokers
Mhm.
entirely, we went from almost entirely a nonprofit and educational book of business to a massively diverse book. And one of the things that I knew was going to happen is manufacturers were going to eat this up. And of course they have. Semi-skilled non-union labor in this country is in a huge, huge shortage.
Mhm.
And health plans like ours, I mean, it blows people away. And so that is perhaps the real secret sauce from the employer's perspective. They have to get the costs under control. That's literally table stakes. But they could do that through crappy benefits just as easily as us. But the consequences are so fundamentally different that the equation turns out to be super easy. And so our retention rate through everything, through COVID, through growth, through changing to brokers, has been climbing. I mean, we were at over 100% on an enrollment weighted basis last 2022 and in the high 90s last year. I mean, these are numbers that in the medical industry are probably unprecedented. And look, we have our problems just like everybody else, the growth business, the complexity of what we do. I mean, we didn't sell through the channel for a long time because it was a complicated product. But by the late 19 timeframe, we felt good that the product was complete and that we had created a unique product against which we can compete with HSA, PPO, HMO, et cetera. And it stood on its own. And our partners have validated that in absolutely stunning terms. And so it's been a really spectacularly interesting experience. But that retention and recruitment story, boy, that's the pocket on this. And it's people say, well, that's a marketing thing. But again, going back to that whole mission of the human rights side of this and the whole issue of equity, it has really resonated across the country. And people say, oh, you're probably all your clients are in blue states. Well, no. Our fastest growing states in the last 2 years have been Louisiana and Texas. And last time I checked, I don't think people would have called those the blue zone. And there's a reason for it. Everybody's got these problems. And it doesn't matter your industry, it doesn't matter your geography, how you keep people believing that this incredibly expensive investment you're making is an add and not a subtract has been really the secret sauce for the employer relationships. And it's allowed the change to be much more comfortable for our community to bring forward.
And that's a great place to end our conversation for today. David Sloves, CEO at Nonstop Health. David, thanks for sharing your expertise with our audience.
I'm delighted. And David, I love your program, and I look forward to having another conversation down the road, perhaps. So thank
It
you.
would be our pleasure. Thanks, David.
Shout out to the crew at Grand River Agency for their awesome post-production. This ShiftShapers podcast is copyrighted content and may not be reproduced in whole or in part without the express written permission of ShiftShapers Solutions, LLC. Copyright 2024.